Thank you, Carlos, for your nice introduction and to the organization for inviting me to talk in this nice symposium. I have no conflicts of interest. And we're going to talk about health inequities and its burden and consequences in the obstructive sleep apnea. And in the end, I will present also the strategies to improve these health inequities in obstructive sleep apnea. So let's go for health inequities. As we can see here, the main marker, one of the main markers of health inequity is the density of physicians around the world. We can see how the African continent and Asia and some parts of South America are lack of doctors, and this is including even physicians devoted to bureaucracy and administrative works, not only physicians working as a doctor. And we can see here a huge difference. According to the World Health Organization, health is the state of complete physical, mental, and social well-being, and not merely absence of disease or infirmity. The quality of health and how health is distributed among economic and social status in a society can provide insight into the level of development within that society. Health is considered a basic human right and a human need, and all human rights are interconnected. Thus, health must be discussed along with all other basic human rights. Here, let me introduce another way of, another definition of health as defined by Trevor Hancock recently, the mandala of health, showing the well-being of body, mind, and spirit in a social, community, personal behavior, taking into account all kinds of physical environment, psychosocial, economic environment, human biology, and human-made environment. Is the same health equality and health equity? Certainly not. Health equality is simply provide every individual with the same resources, but not taking into account any social circumstances, any background of the individuals. Whereas health equity indicates that the resources must be allocated based on an individual need-based principle. We cannot give everything to everyone because some people have a lot of resources, and whereas others don't have resources. So that term would be the equity in health. This inequity may include differences in the presence of disease, health outcomes, access to healthcare between population with a different race, ethnicity, gender, sexual orientation, disability, or socioeconomic status. Health equity is defined by the Center for Disease Control as the state in which everyone has a fair and just opportunity to attain the highest level of health. So it's like taking into account the status of every individual. It is closely associated with the social justice movement, with good health considered as a fundamental human right. Health inequality is the term used in a number of countries to refer of those instances whereby the health of two demographic groups differs despite similar access to healthcare services, which occurs in many countries. They have same access to healthcare system, but the outcomes are very different. Although it is important to recognize the difference between health equity and equality, having equality in health is essential to begin achieving health equity. The importance of equitable access to healthcare has been seen as crucial to achieving many of the Millennium Development Goals. One of the main um, markers of health is, of course, life expectancy at birth. As you can see on the red, on the left side, we have the countries in the world with the highest life expectancy at birth, mainly in Asia and Europe. And on the other hand, the right column, the countries where the life expectancy is worse at birth, mainly African countries. So let's talk about its burden and consequences in obstructive sleep apnea. Approximately half of people worldwide have obstructive sleep apnea, according to a meta-analysis and meta-regression study recently published. This prevalence of up to 54%, including all type of obstructive sleep apnea, they stated also that high BMI, increasing age, and mild gender are described as risk factors in the literature. Here we can see the prevalence in countries where the studies were performed in the world. So there are many countries where they didn't even perform any study of prevalence of obstructive sleep apnea. And we can see some patients where sleep apnea can be related to high BMI, like United States or South Africa, whereas other countries where it's not related to BMI, like China or Asian countries. Here we can see, regarding the BMI, the world population, which is 8,000 million. People who died of hunger today, 20,000. The nourished people in the world, about 1,000 million. Overweight people in the world, about 2,000 million. And obese people in the world, almost 1,000 million. But what's more interesting is that only in the United States, spendings for weight loss programs are 1,027 million, whereas spending for the consequences of obesity are 4 times higher than spendings in the weight loss programs. This is bad news for the health in the world regarding obesity, as the number of obese people is estimated that's going to grow over the years. We have prevalence of 11.4 2010, estimated 16.1 2025, and 17% 2030. So this is a very severe epidemic, not only in the developed countries, but worldwide. Here we have the distribution, geographical distribution of obesity as the data from the World Health Organization. It's not only United States, Mexico, but also in the Middle East, South Africa, Russia, Europe, Australia, Argentina. Many countries, this epidemic is increasing. But there are many cardiovascular diseases associated with obstructive sleep apnea, which includes hypertension, heart failure, stroke, cardiac arrhythmia, myocardial ischemia and infarction, and pulmonary artery hypertension. Let's see how these are distributed worldwide. As we have a look at high blood pressure distribution in the world, we can see that the highest rates of uncontrolled high blood pressure are in Africa, whereas in United States, South America, China, Australia, blood pressure is better controlled than in African countries. regarding the distribution of heart disease, you have to take into account that these data are based in dailies, so loss of quality day life, not incident of ischemic heart disease. So this is related to the outcomes after the ischemic heart disease occurs and is treated. So the poor outcomes, the higher losses in dailies. So in this map from the NIH, the poor outcomes and the bigger losses of dailies occurs in Russia and Eastern Europe. Regarding stroke, you will see now the difference between this slide and next slide. This is the standardized annual prevalence per 100,000 people with ischemic strokes. As you see, the prevalence is higher in the United States and Canada than anywhere in the world. But if we look about ischemic stroke dailies rates, the losses of dailies, then it comes very different. It comes to Asia and Africa, the loss of dailies, since in the United States, given their healthcare system and their recovery institutions for the people with strokes, the dailies are quite lower than in Eastern Asia. And finally, I would like to talk about what can we do to improve these health inequities in obstructive sleep apnea. This is based on the American Heart Association regarding the strategies for promotion and health style in clinical settings. What would be the ideal for cardiovascular health? Of course, it will include healthy diet, physical activity, to control increased BMI, stop smoking, of course, adequate sleep, and psychological well-being. And as it comes more and more recently, close contact with the patient to assess, advise, agree, assist, and arrange, all in agreement with the patient, so that the compliance with the treatments and the advice will be higher. What can be the medical strategies to improve the outcomes? First, involve more doctors and health workers in screening and treating obesity, OSA, and other sleep disorders. Of course, pneumologists, neurophysiologists, neurologists, but also can be involved occupational medicine doctors, family physicians, geriatricians, endocrinologists, internal medicine doctors, cardiologists, and so on. And why not nurses, dietitians, and pharmacists? In some countries, pharmacists are doing screening of sleep apnea with small devices, and that can be also a good help. We need to strengthen the idea that sleep apnea also is related to insomnia, and spread this idea in our colleagues, doctors, and health workers. And also to introduce the health sleep disorders, which should be related to sleep apnea. Another medical strategy can include screening of obstructive sleep apnea and other sleep disorders in primary health care, in driver's evaluation before license and periodically, and occupational health. This should lead to cut huge waiting lists for obstructive sleep apnea studies in many countries, which are mainly, basically, in the public healthcare system. Another strategy to improve can be to improve medical devices for the diagnosis and management of obstructive sleep apnea and other sleep disorders in order to low cost of medical devices, simplify interpretation, improve accessibility, and spread the use of these medical devices to other types of doctors. and also use all available medical data to improve diagnostic in sleep disorders, like use the Holter ECG 24 hours recording with adequate software. They can make one kind of a screening of a sleep apnea, and many cardiologists normally don't pay attention to this and don't refer these patients to making one test of obstructive sleep apnea. On the other hand, suspicious data from ambulatory blood pressure measurement recordings 24 hours, the non-deeper pattern, is frequently related to obstructive sleep apnea, and these patients should be related to sleep clinics for evaluation. Also, recently developed night pulse oximetry devices can increase the screening of obstructive sleep apnea. And finally, end users' medical devices like watches are starting to improve the diagnosis of sleep apnea, measuring 24 hours pulse oximetry. And there are more advanced devices like watches, which are going to add to their software artificial intelligence, so that in the coming years, the many more data are going to bring from these watches, which are not just toys like in the past, but they are medical devices class 2A with certification from FDA and CE. Also, we can improve the compliance with the treatment of obstructive sleep apnea with more adequate advice and supervision of current devices and disposable user interfaces. Since the compliance with the treatment of obstructive sleep apnea doesn't reach even more than 70%, the other 30% of non-compliant patients should be encouraged and given close advice so that they can comply with the treatment. With better devices which are better tolerated by patients, and with more publishing and advertising in direct relationship between OSA treatment and outcomes in terms of quality and mortality. This is one paper published recently where they found that the adherence of CPAP treatment more than 4 hours a day is associated with a reduced recurrence risk of major cardiac or cerebrovascular events by 31% reduction, which is a lot, 31% reduction in MACE. So we need to encourage the patients with close advice, with better devices, to comply with the treatment. Thank you very much.